marked tonsillar hypertrophy and a low sitting tongue and collapse generated all at the tonsil level, and then failed treatment, unblock the nose if it hasn't already been performed pre-phase, and go on to trial CPAP again when the nose has been improved, or consider behavioural therapies or interventions to improve CPAP compliance. If they're successful, continue your regular surveillance, downloadable compliance data, and if they fail with the repeat trial of CPAP, plus or minus presentation at a multidisciplinary team meeting, then we look at staged surgical interventions or protocols, or trialling a mandibular advancement splint. And those interventions, or the protocols in Australia, have altered from those of Riley and Powell to reflect what we do more classically, that is improving the nose first, looking for that suitable candidate for a modified U-P-P or tonsillectomy, plus or minus some simple channeling or radiofrequency to the tongue, but considering the unsuitable candidate, looking for combining the modified U-P-P with palatal advancement and a tongue procedure according to your comprehensive clinical polysomnographic and other assessment, whether it be a tongue tensing procedure, an aggressive tongue reduction procedure, a limited tongue reduction procedure, or something in between. And you can often combine your tongue reduction procedure with lingual tonsillectomy, particularly if it's simple radiofrequency or coblation channeling to the tongue. And then phase 2 intervention becomes a further tongue procedure if it's needed or necessary on your repeat assessment, or something to the lower airway that might involve a hyoid procedure for failed intervention here, plus or minus revision palatal surgery if it's deemed necessary, which in my hands is extremely rare, or maxillomandibular advancement referral for that intervention. So I'll leave it at that. Sorry, I've gone a little bit over time, and I'll hand on to the next one.
Thank you, Dr. Stewart. Just please wait. There will be a collective questioning in the end. Now, can I request the next speaker, Dr. Vijay Krishnan. We've seen Vijay operating yesterday. He is a consultant ENT surgeon in Madras ENT Research Foundation, and he is specially interested in the field of OSAS, and he has been trained for it. Without wasting much time, Vijay, please go right ahead.
Yeah. Thank you so much. Good afternoon, ladies and gentlemen. Welcome to Chennai. And I think we have wonderful sessions in the morning. Can I have my slide? Yeah. So almost Stuart Mackey explained whole how to assess and what are the protocols to be followed. So I would like to go very fast in this aspect. So we all know that obstructive sleep apnea is a common disease in adult and pediatric age group with myriad of presentations. So we should address this issue with proper guidelines and protocol. We should know when to choose a patient, what procedures to be done, how to do. Without any much deviation, we should follow some protocol which gives very good success rate. There are so many protocols out there which should not be confusing, and we should not tie our hands to do nothing. So it should be very clear and simple to follow why we should treat and sleep apnea, which really impairs the daytime activity sleepiness and takes away the quality of life. It impairs the relations between the spouses and reduce alertness, which is very much dangerous, leading to increased risk of road traffic accidents. It has almost evidence that it's 1 to 12-fold increase in accident rates among patients with OSAHs. It is estimated to cause about 20% of road accidents on major highways. If you see this following video clip, which I took from YouTube, you could see how Can you click that? So this gentleman is having a daytime sleepiness. He just knocks up for a second, and he just see it's a camera fitted in her car. Yeah, if there is any co-passenger, that's it. That's a worst situation to happen. So India is a developing country where these management and evaluation takes major constraint on the economy, and as there is no much coverage with national or a private insurance company to participate to help the candidates, it is a very difficult scenario to evaluate the patient. So the aim of the protocol should be on evidence-based recommendation for the diagnosis as well as the management, to guide the surgeons to recognize the symptoms of this common disorder and to prioritize the referral to proper neurologist or a cardiologist, whoever, that referral to be done, and to understand how the sufferers may be investigated and which treatment modalities are currently available. And sleep disorder breathing is a spectrum of disorder, and we are in the one spectrum of this disorder we are seeing, and we primary snoring, upper airway resistance syndrome, and obstructive sleep apnea syndrome. These are the part of the spectrum we are looking at. We have 2-3 group of patients will be attending in our OPD. Those who are at high risk for OSA, and some patients will be coming with the complaints of snoring and sleep apnea, and there are some other patients who may be coming with comorbid conditions. So we have to evaluate the patients with morbid obese of more than 35, with congestive heart failure, atrial fibrillation, or refractory hypertension with antihypertensives, and type 2 diabetes where the metabolic syndrome is associated, patients with nocturnal dysrhythmia, stroke, etc., etc. These patients are at high risk and has to be evaluated for OSA symptoms. And these are the questions we have to include in our routine evaluation, like when the patient is obese or when the patient is having retrognathia, whether the patient is having a daytime sleepiness, whether the patient has snoring or having hypertension. So there are so many questionnaires available, but the EPO sleepiness scale and the stop bank questionnaire are the prime questionnaires which we follow. And this is a sleep study pro forma we follow. And we have list of EPO sleepiness question, and along with that we have a stop bank questionnaire which indicates the symptoms and severity. Though it is not 100% correlates, it has major role in clinically evaluating the patient. So with some patients have daytime sleepiness and in night symptoms. We classify them as daytime symptoms and night symptoms. The daytime symptoms like excessive daytime sleepiness, fatigue, neurocognitive dysfunction, personality changes, and depression and behavioral disorder. And night symptoms like snoring, witnessed apnea, fragmented or restless sleep, nocturia, aneurosis, a nighttime sweating, a nightmare, morning headache, etc., etc. So the role of spouse is very much important when you are assessing these symptoms. The priority screening for OSAS comes when there are with the commercial drivers reporting road traffic accidents, diabetes in type 2 particular, clear-cut upper airway abnormalities like static obstructions like very large tonsils or significant retrognathia, and neuromuscular disorders which will maybe cause for a dynamic obstruction, which will at risk of nocturnal hypoventilation, and patients with COPD and unexplained cardiomyopathy also. These patients should go for a screening for OSH. So we all know that it's increasing demand for this issue, where we see a lot of patients in the recent past. So there is a demand for sleep studies and evaluation. So when you are looking at the clinical, I'm not going through I'm just running fast because this being covered. So when you are looking at the nose, we will be looking at the valvular collapse, septal deviation, turbinate hypertrophy, and examination of the nasal cavity for a MOS or any polyp. And we do a diagnostic endoscopy looking at the nasopharynx for the adenoids or any other MOS blocking the airway, and salpingopharyngeal fold, is there any hypertrophy, as Dr. Vikas always says. And when you're looking at the throat, you have to look for from the outside, we have to look for retrognathia, and we have to look for higher mandibular distance, neck circumference, and grade the tonsil, and look for the tongue position, whether it's 1, 2, 3, or 4, and whether there is any having soft palate hypertrophy or uvular hypertrophy, which is clearly blocking the airway. And video laryngoscopy to be done to document the issue. And we also have to look for any comorbid conditions like hypothyroidism, diabetes, pulmonary systemic hypertension, and COPD. And now we are going to choose the patients for further investigation. With all these clinical symptoms, we have to choose and to know where the level of obstruction and to know the physiological aspect of the problem. So for the anatomical level of obstruction, sleep MRI or a dynamic MRI can be done, or a drug-induced sleep endoscopy is done. If most of us, if we couldn't do either of these, at least we should do a flexible nasal and laryngopharyngoscopy to look into the nasopharynx and hypopharynx, and it is mandatory just before doing any interventional procedure. So, level of obstruction, we have 3 levels of obstruction according to Fujita's classification. So it's a retropalatal or retrolingual, and exclusively retrolingual, which is type 3. So this is a dynamic MRI. You can see in this patient came with a primary snorer. Nasal component is much one, then there is adequate space behind the palate and behind the tongue base. Next. Yeah. Type 1. Open the PowerPoint. Can you go back to the PowerPoint? So in this dynamic MRI, you could see the retropalatal block, which is the edematous palate, which is blocking the airway. Go to the next video. Two. So this is about type 2, both retropalatal and retrolingual collapse. You can see. Next video. This patient basically having a retroglossal and purely retroglossal block, and you have adequate space behind the palate. Basically, this is because of the retrognathia issue, where we can do a mandibular advancement. Come back to the PowerPoint, please. So regarding the polysomnogram, the gold standard is type 1 is the most recommended one, where we do polysomnogram with 7 channels, EEG, OG, EMG, etc. Or at least we should do type 3 before doing any interventional procedures, where we measure 2 respiratory effort channels, airflow and heart rate and ECG. No, it's not working. Yeah. So basically, if you look into the flow chart, we have 3 category of patients who comes with snoring, who are at high risk, and who are having other comorbid conditions. If there are any sleep disorder symptoms related to that, they have to be evaluated, sleep evaluation to be done, And if it is confirmed, we will be doing a dynamic MRI, DICE or a sleep study to know how much significant the problem is. If the AHI is more than or equal to 5, that is significant AHI plus symptoms, we discuss the treatment option. So the treatment option, the first and foremost thing is, most important thing is lifestyle modification and weight reduction, and doing regular exercise and diet regulation, patient counseling. So patient counseling is most important part of the management. We should ask them to go for a CPAP titration, and if there is a dynamic obstruction, it is a must to use a CPAP trial, and if there is a static obstruction, we can plan for surgery. It is just like we are asking, dealing with a patient with otosclerosis. We give both options of hearing aid and the surgery. We tell them hearing aid is very simple, you just wear it, you can hear it, but you have to use it daily. Once you remove the hearing aid, you are back to square one. Like same thing, you have to use the CPAP daily. If you are without CPAP, then you are sleep apnea patient. So that message has to be clearly explained to the patient, and the failure rate of each and every surgery has to be clearly explained to the patient. So the recommended protocol for choosing a patient for surgery is a CPAP trial if it is not comfortable. Then the second criteria will be a BMI and AHI, which is very high. If it is very high, the success rate goes down. And if it is also according to the site and level of obstruction, if it is multiple, the success rate is also going down. So it is not like this patient will go for this surgery. So it should be tailor-made for each and every patient. We have to assess in all aspects. Each and every patient is not the same one. So we have, if there is any nasal issues, it can be addressed, and if there is any palatal collapse, we have a lot of palatal procedures which will be explained in detail tomorrow. I am just skipping. So most important part of our thing is when not to do surgery. So patients, unmotivated patients, where they don't care about their lifestyle, they just work without any exercise, no point in asking them for a surgery. And patients with morbidly obese BMI, with severe OSAS, we should motivate them to reduce their weight, and then we can plan for surgery. So how we are going to assess the outcome? When there is a resolution of sleepiness, improvement in daytime work, quality of life, and adherence to therapy with proper sleep hygiene, and weight loss for overweight and obese patients. Usually we repeat sleep study after 6 months. I think the take-home message will be sleep MRI, DICE, and fiber optic and laryngoscopy has obviated the need for cumbersome cephalometric measures, and in properly selected cases, that is most important. In properly selected cases and properly selected procedure, we can yield a gratifying result, and we should definitely know when to not the surgery and when to refer the patient to colleague. Thank you.
The next speaker is, can you give the mic? Okay. The next speaker is Dr. Srinivas. We've seen him yesterday. He is a consultant ENT surgeon in Rainbow Hospital, and he has a large number of papers to present, has presented, and his topic for today and this afternoon is drug-induced sleep endoscopy. Without wasting time, Dr. Srinivas, could you please proceed?
Good afternoon, everybody. Teachers, colleagues, friends. One thing I should say coming in at this point, that the quality of the conference, what is going on right now, and the scientific content is amazing. And I think whoever is sitting there, and I should also compliment the speakers before me, that the scientific content has been excellent. So I think we should keep up the momentum and take it further. So we are at this particular stage in the conference where now we're slowly moving on to assessments. Like I said yesterday, there are multiple ways to skin a cat. What I'm going to talk to you about is one other way of assessment. So I'm going to talk about drug-induced sleep endoscopy, which for a lot of you is not a new thing. Now, it started way back in the early 90s in the UK, where Pringle and Croft came up with this beautiful idea. Since you can't go into people's house and put scopes into people's houses and bedrooms and put scopes through their noses and see what's going on, is there some way with a wire media in between where we can actually mimic sleep in an artificial environment and try and see what is going on, because we are trying to assess and validate and treat obstructive sleep apnea. So why is this very important? Now, as you all see here, we all know that overnight polysomnography, whichever level it might be, is a gold standard in diagnosing sleep apnea. However, it fails to identify as to which patients are likely to succeed with alternatives of sleep apnea. I'm not only talking about surgery. I'm also talking about other means. I'm talking about mandibular appliances. I'm talking about, strips. I'm talking about other means. So multiple evaluation techniques have developed to examine the individual pattern. Remember the word pattern of airway obstruction, each with its own strengths and weaknesses. We've just seen Vijay come up with beautiful MRI pictures, dynamic cine MRIs. So currently, again, there is no gold standard method to determine the level of airway collapse. However, the most commonly done for most of us is the Muller's maneuver in an awake supine patient. There are others. There are plain cephalograms, cephalometries, there's CT scans, there is CineMR. So one such method is drug-induced sleep endoscopy. Now, what are the key features of this kind of assessment? So what you're basically doing is you're using different pharmacological agents to achieve sedation. The goal is to reproduce the upper airway behavior, which is similar to the one in sleep which is happening to the patient. So what are the indications? Who are the patients that you would like to take up? It's indicated when you want to do surgery. It's indicated when you want to put a patient through some kind of an appliance. There are no absolute contraindications. Well, there are certain limited relative contraindications. The AHI being if they are more than 70. I was just baffled to see that sleep report of the person who's like 100. I've never seen such a big AHI in a patient. So, well, this can be a relative contraindication. There are no absolute contraindications because remember, you're doing it in a very controlled environment. So what are the prerequisites? Yes, patient should have a basic cardiorespiratory monitoring, must be possible to administer oxygen if needed, and these two things is the best way that you can mimic sleep, a target-controlled infusion system for propofol or midazolam, but unfortunately we still don't have it in India. A bispectral index scoring system, which we now have and which me and Vikas have implemented doing with bispectral index scoring, definitely validates whatever you're doing, bringing you closer to a real sleep situation. So the patient shows up in NPO, you give something like glycopyrrolate half an hour before the surgery, a topical anesthetic not to overflow too much into the pharynx. This is important. So you can use your 10% lidocaine spray, but it shouldn't be too much to kind of go trickle down into your throat and cause numbness in the throat pharyngeal receptors. So view with a flexible scope on the screen, and important to help with the microscope so that you're actually recording acoustic signals, the snoring and the visual signals should be recorded simultaneously. Very shortly about the drugs. This is the pharmacokinetics and pharmacodynamics. Well, they're all there in the textbooks. So what you're doing here is, if you're taking propofol as the drug of your choice, it should be 1.5 milligrams per kg, or could be a continuous infusion. I would suggest that please don't do it by yourself. Yes, we can play around with midazolam and propofol by ourselves, nothing will happen, but always keep